Hi everyone, my name is Ed and I am a current PGY1 resident at Emory University Hospitals. And today I wanted to present on my research examining the effect of immunotherapy on brain metastases in non-small cell lung cancer. My collaborators and I have nothing to disclose. So to begin, I want to establish a little bit of background. Lung cancer is the leading cause of cancer-related mortality in both men and women. Approximately 10% of patients with non-small cell lung cancer will exhibit brain metastases at baseline, and upwards of 25 to 40% of these patients will develop brain metastases at some point during the course of their disease. Unfortunately, brain metastases are associated with a poor prognosis, with the median survival for patients receiving radiation therapy being anywhere from 2.5 to 5 months. Historically, radiation therapy and local surgical resection comprise the backbone of therapy for patients with non-small cell lung cancers exhibiting brain mets. However, radiation therapy is associated with poor tolerability due to toxicities such as radiation necrosis and cognitive decline. The advent of targeted therapy and immunotherapy have given the opportunity for clinicians to target unique patient-specific mutations and modulate immune function. Immunotherapy agents aim to enhance host immune function by inhibiting the deactivation of T cells, which in turn lead to anti-cancer effects. Immunotherapy agents that are commonly used in the treatment of metastatic non-small cell lung cancer include pembrolizumab, atezolizumab, and ipilimumab. The decision to treat with combination immunotherapy or chemotherapy or immunotherapy alone is made on a patient-by-patient basis. Poor baseline functional status is an example of a reason a candidate may not receive upfront chemotherapy. All in all, the degree to which these immunotherapy agents penetrate the central nervous system is currently unknown and provides an exciting area for research. Therefore, the objective of this study is to characterize the effect of immunotherapy on disease progression in patients with metastatic or recurrent non-small cell lung cancer. The primary outcome of this study was to find its progression of brain metastases while receiving anti-cancer therapy. Secondary outcomes in this study included the progression of the disease to the liver as well as other sites of the body, clinical benefit of treatment with immunotherapy, which was defined as the amount of time a patient remained on treatment until disease progression or initiation of a new agent, and the safety profile, including the toxicities and adverse effects associated with immunotherapy, the need for immunosuppressive therapy initiation due to immune-related adverse effects, and the need to initiate thyroid treatment. This was a retrospective chart review conducted at the Winship Cancer Institute. Patients with metastatic or recurrent non-small cell lung cancer receiving immunotherapy with a PD-1 or PD-L1 inhibitor with or without the concomitant use of chemotherapy were included in this study. Patients were excluded if they possessed EGFR or ALK mutations or if they were enrolled in clinical trials. A total of 265 patients were initially screened for eligibility. Out of these 265 patients, 130 or 142 patients did not meet eligibility criteria. Common reasons included an inadequate trial of immunotherapy, the lack of imaging to quantify progression after receipt of therapy, or enrollment in clinical trials. This left 123 patients for analysis. Out of the 123 patients, 43 patients received immunotherapy alone and 80 patients received combination immunotherapy and chemotherapy. As we can see, baseline characteristics were relatively similar between groups. Our typical patient was an older non-African American male that was a former smoker. Most patients enrolled had non-squamous cell, non-small cell lung cancer and an ECOG performance score of 1 or 2. As we can see, all patients analyzed received pembrolizumab as their immunotherapy agent. And in the chemotherapy immunotherapy arm, most patients received chemotherapy with carboplatin and pemetrexed or carboplatin and paclitaxel in addition to pembrolizumab. Driver mutations were similar between groups other than that of STK11, which was only present in the immunotherapy and chemotherapy arm. Additionally, PD-1 expression was higher in the immunotherapy groups, which was to be expected. The baseline metastases between groups was relatively similar. Common sites of baseline metastases included the brain, bone, and thoracic lymph nodes. This table provides a summary of the progression of metastases while patients receive therapy. We observed similar rates of brain metastases between both groups, with the rate of progression being about 10 to 15%. Additionally, there were similar rates of progression observed for the liver as well as other sites of disease. The most common sites of metastatic disease included bone, contralateral lung, as well as thoracic lymph nodes. The clinical benefit of treatment is presented on this slide. And as you can see, the durations of clinical benefit were similar between groups, with most patients experiencing a clinical benefit from anywhere between 6 and greater than 12 months. When looking at safety outcomes, we can see that both groups had similar rates of discontinuation due to adverse effects, the need to start immunosuppressive therapy for immune-related adverse effects, and initiation of thyroid replacement. To summarize, we observed similar rates of brain metastases between groups treated with immunotherapy and combination immunotherapy chemotherapy. We did see a higher proportion of patients with the STK11 mutation in the immunotherapy chemotherapy group, and it's thought that the presence of STK11 mutations may diminish the efficacy of immunotherapy, which may have confounded our results. Finally, we observed similar durations of clinical benefit seen between groups, with most patients experiencing a clinical benefit of greater than 12 months. There were several limitations to this study. The retrospective nature of the study limited the information that was obtained to chart information in the EMR. Additionally, the number of patients that have currently been analyzed is not sufficient enough to meet power requirements, and additional collection and data analysis is currently being performed. And finally, variability in clinician judgment when defining progression and making the decision to change therapies may have introduced a confounder to these results. So in summary, immunotherapy monotherapy results in comparable rates of disease progression as well as clinical benefit when compared to combination chemotherapy and immunotherapy. This data suggests that we may be more comfortable in considering immunotherapy monotherapy in select patient populations, such as those with poor baseline performance scores or those who may not be able to handle intensive chemotherapy. However, additional studies are required to fully characterize the benefit of immunotherapy on disease progression in this patient population. I would like to take this time to thank my project collaborators. And my assessment question is presented on this slide. Thank you for your time and viewing my presentation.